Okay. So it is 1 o'clock and good afternoon. My name is Dr. Amy York, and along with Dr. Kathy Larson, we welcome you to the dissertation defense of David Doubblestein, a University of Michigan-Flint PhD in physical therapy candidate. Dr. Larson and myself serve as co-chairs, and Dr. Alon Goldberg and Dr. Brian Spinelli are members of David's PhD committee. Please make sure to keep yourself muted during the presentation. David will present his dissertation over the next 45 minutes. After that time, you will have the opportunity to ask David questions regarding his work. At this time, I'll turn the presentation over to David.
Hello, and welcome to my dissertation defense on the status of lymphology education and practice in physical therapy. The objectives of this dissertation defense are as follows. I will outline the broad spectrum of the dissertation. And then I will briefly summarize the key components of the published studies 1 and 2. From there, I will examine the key components of study 3, which will be the focus of this dissertation defense, as it is my most recent research endeavor without publication. After that, I will summarize and infer the significance of the dissertation conclusions, and then identify prospective research stemming from the dissertation. But before we proceed, I will give you some operational definitions. First, lymphology. Lymphology is the study of the lymphatic system, including its anatomy, physiology, and pathophysiology. And in medicine, it would include the study of associated interventions. One pathology that is studied in is lymphedema. Lymphedema is an abnormal accumulation of fluid and protein molecules in the tissue spaces. Lymphedema is evaluated and treated by certified lymphedema therapists. And they have 135 classroom hours on complete decongestive therapy and edema conditions. They can be a nurse, an occupational therapist, a CODA, a physical therapist, a PTA, a physician assistant, a chiropractor, a massage therapist, and a certified athletic trainer. However, most certified lymphedema therapists are PTs and OTs. Now, some certified lymphedema therapists are credentialed or certified by LANA, which is the Lymphology Association of North America. And it is a nonprofit organization committed to establishing and maintaining standards of education, qualification, and examination for certified lymphedema therapists. Lymphedema therapists may use complete decongestive therapy to conservatively treat lymphedema. And the three main components of complete decongestive therapy are manual lymphatic drainage techniques, compression, either bandages, garments, or even devices, and exercise. Now, the purpose of this dissertation was to examine how lymphology is integrated into the field of physical therapy, including professional physical therapy education and practice. The overarching aim of this dissertation was to advance lymphology aptitudes among faculty, post-professional educators, clinicians, and students. But before I summarize these studies, I will share with you my interest, no, my passion on the topic of lymphology from physical therapy point of view. You see, the American Physical Therapy Association vision statement states that we're transforming society by optimizing movement to improve the human experience. Physical therapy promotes the movement system, and that movement system is the integration of body systems that generate and maintain movement of all levels of bodily function. We do this by examining and evaluating and providing interventions on these major body systems: the cardiovascular, the integumentary, musculoskeletal, neurological, pulmonary systems, and yes, the lymphatic system. The lymphatic system interrelates the immune system and the cardiovascular system. And yet, in and of itself, it stands alone as a distinct major body system. And this major body system is responsible for many, many functions, but most commonly known for maintaining fluid homeostasis and resolving edema. Damage to the lymphatic system can result in lymphedema, chronic edema. It is estimated that 140 to 250 million persons worldwide have lymphedema. In the United States, it's estimated that 1 in 1,000 persons have lymphedema. An imbalance of fluid homeostasis, chronic edema, lymphedema, they all exist in all the disciplines of physical therapy, including oncology. On the left, breast cancer-related lymphedema. In the center, testicular cancer-related lymphedema. And on the right, head and neck cancer-related lymphedema. Women's health, idiopathic cyclic edema. About wound care, venous ulcers, chronic edema. Geriatrics, chronic venous insufficiency, dependent edema. Cardiopulmonary, congestive heart failure, chronic venous insufficiency. How about pediatrics? Primary lymphedema. And then sports medicine, chronic joint effusion, arthrofibrosis. And neurology, dependent edema, and that loss of muscle pump. In orthopedics, lymphedema from a total knee arthroplasty or traumatic injury. So I believe that physical therapists that engage lymphology concepts into their discipline are able to optimize human movement through edema management and transform society by decreasing the continuum of disease related to the imbalance of fluid homeostasis. You see, being more attentive to lymphology and physical therapy can improve that human experience. Okay, so let's get started. Let's dig into these studies. The first study, faculty survey on the status of lymphology education in professional Doctor of Physical Therapy programs. The purpose of the study was to describe current and typical lymphology content within professional Doctor of Physical Therapy programs, and to identify whether lymphology content is perceived as entry-level material amongst professional DPT faculty who were responsible for teaching lymphology and faculty who were not teaching on lymphology. This was a cross-sectional online survey research design. And I developed a survey that had 37 questions that were aimed to gather information on the lymphology content being taught, the hours teaching lymphology content, the barriers to teaching lymphology content, and those perceptions on entry-level lymphology content. The face validity of the survey was attested by myself and a fellow researcher with survey research experience. Prior to disseminating this survey, I conducted a pilot study with 6 content experts to see if the purposes of the study were answerable from the survey. And they were. These content experts, they also confirmed the content validity of the survey by agreeing that there was clarity and relevancy of the overall survey and survey items. The inclusion criteria were professional Doctor of Physical Therapy faculty in the United States who taught and did not teach lymphology curriculum. I conducted convenient sampling by disseminating 221 emails with survey links to Doctor of Physical Therapy program directors. And then I asked those program directors to further disseminate that link to their faculty. We had 43 professional Doctor of Physical Therapy faculty respond to the survey. 38 of them taught on lymphology, and 5 did not teach on lymphology. The 38 faculty that taught on lymphology responded to the questions on hours teaching lymphology content. And as you can see here, they conducted a mean of 2.8 lecture hours on anatomy and physiology, and 2.5 lecture hours on pathophysiology, 1.6 lecture hours on examination, and 2.0 lab hours on examination. But what is most concerning is the range of hours spent on these topics. They are quite variable. Take a look, 0.5 to 14 lecture hours on anatomy, physiology, and even pathophysiology, and 0.5 to 6 lecture hours on examination, and 0.5 to 8 lab hours on examination. Here we can see the lecture hours and lab hours spent on teaching on the topics of interventions. Of note, the mean lab hours exceed the lecture hours for each topic, being compression devices, manual lymph drainage, and compression bandaging. Now, similar to that previous slide, I want to point out the significant range in lab hours spent teaching these interventions. 0 to 6 hours for compression devices, 0 to 8 hours for manual lymph drainage, and 0 to 6 hours for compression bandaging. So we can conclude that there is one or more programs that do not teach on one or more of these interventions. I then asked all the respondents, all 43 of them, their opinion about entry-level status of discrete curriculum topics. And the respondents used the scale of entry-level, non-entry-level, and not sure. A rather high percentage of respondents had the opinion that anatomy, physiology, and pathophysiology content were entry-level. Now, I want to highlight a few topics of interest that will relate to the next 2 studies. Looking at curriculum topics related to examination and using outcome measures, we can see that a majority perceived comorbidities, functional limitations, and examination labs as entry-level content. Looking at the topic related to interventions, more than half of the faculty felt that manual lymphatic drainage techniques and compression bandaging were entry-level material. And then a majority of the faculty had the opinion that compression garments and devices were entry-level. Yet what is interesting is that there is a rather equitable distribution about whether complete decongestive therapy is entry-level, of which manual lymphatic drainage techniques and compression are the 2 main components. It is important to note that there were no significant differences between groups in their opinion about entry-level material. I also examined the barriers to integrating lymphology content into the DPT program and discovered that there were 62.8% of the respondents felt that was due to lack of time, and 44.2% of the respondents felt that was due to lack of faculty expertise. 37.2% of the respondents felt that it was due to content being undervalued by students and faculty. Now, beyond these discrete choices, there is one more barrier, and that is 30% of the respondents had the opinion that lymphology material was beyond entry-level knowledge. And I state that in light that even the National Physical Therapy Examination contains lymphology content. Okay, so in the previous study, I had discovered that manual lymphatic drainage techniques were considered entry-level material by 59% of the faculty. So this promoted my curiosity if these techniques were even being used on musculoskeletal conditions. So the title of this study is Effects of Manual Lymphatic Drainage Techniques on Conditions Affecting the Musculoskeletal System, and it was a systematic review. The purpose of the study was to examine if the addition of manual lymphatic drainage techniques to conventional rehabilitation on people with conditions affecting the musculoskeletal system were effective. My co-author and I followed the PRISMA guidelines in conducting our systematic review. Our population of interest were humans aged 5 years or older, and they had to have a confirmed musculoskeletal condition. Our intervention of interest was manual lymphatic drainage techniques from various tenets. You see, because manual lymphatic drainage techniques can be different from each other, and they're different because they have different developers like Vaughter, Chickley, Artsberger, and Leduc. Now, we screen titles and abstracts using a study selection criteria that we defined. There were not a lot of studies on this topic. However, ultimately, we did find 5 studies that were included and met our inclusion criteria. They were all randomized controlled trials. We used the Pedro scale to grade their internal validity scores, which were good, except for one, which was fair. And we decided to include this study because it brought in the aspect of compression with the manual technique. Now, I want to draw your attention to the fact that the studies were heterogeneous in the population of interest. Heterogeneous meaning diverse. While they all investigated manual lymphatic drainage techniques, they had a diverse population with different classifications of edema. For instance, Nyes and Rowenho had a population that included subacute edema, status post-distal radius fracture. And Picones and Ebert had a population of status post total knee replacement with acute edema. Ikisi studied the effects of manual lymphatic drainage techniques on fibromyalgia, which is a chronic condition. And Topuz studied a population of below knee amputation with acute edema. In addition to these heterogeneous populations in the studies, unfortunately, there were also heterogeneous outcome measures which prevented a robust meta-analysis. Therefore, we used the Cochrane Grade Guidelines and the American College of Chest Physicians Guidelines to guide our process in measuring the strength of the body of evidence for the use of manual lymphatic drainage techniques on conditions affecting the musculoskeletal system. Our consensus from the scoring using these guidelines was that there was moderate evidence supporting the efficacy of manual lymphatic drainage techniques for the treatment of conditions affecting the musculoskeletal system in combination with conventional rehabilitation to reduce pain and to improve patient-reported outcome measures for functional activities and quality of life. We also found moderate evidence supporting that manual lymphatic drainage techniques are associated with lower health care utilization, edema reduction, and improving range of motion. So, looking back at those last 2 studies, I had discovered that faculty teaching Doctorate of Physical Therapy curriculum agreed that a majority of the lymphology topics were entry level except for complete decongestive therapy. And this included the lymphology topics of examination, comorbidity impairments, and reporting functional limitations. I also discovered that the randomized controlled trials that were included in the systematic review presented with heterogeneous or diverse outcome measures, and that prevented a robust meta-analysis. So this led me to investigate what outcome measures are being used by certified lymphedema therapists in the clinical practice. So the title of this next study is Use of Outcome Measures by Certified Lymphedema Therapists on breast cancer survivors with breast cancer-related lymphedema. Now, before I summarize the study, I need to define some terms again. So when a patient with breast cancer-related lymphedema comes for therapy, the therapist will conduct an examination. The certified lymphedema therapist will conduct and investigate outcomes. And outcomes measure a change in health status. They are often categorized in domains related to health status, such as volume, joint function, balance, and quality of life. These outcomes require a measurement, and the measurements are obtained by standardized outcome instruments and measures. They have been referred to in the literature using different terms, such as patient-reported outcome measures, which include measures like the SF-36, the FIM instrument, or the DASH instrument. They've also been referred to as performance-based or clinician-reported outcome measures. And some examples would be circumference, dynamometer, a timed up and go, a goniometer. The term standardized means that they have a specific protocol for implementation and interpretation. And of note, outcome measures can be examined for their psychometric properties, meaning their validity and reliability. Now, in this study, I have referred to standardized outcome instruments and measures as outcome measures. So I started framing my literature search by understanding the value of outcome measures. And I discovered that outcome measures are essential to evidence-based practice, and that outcome measures are incorporated in the examination and provide a foundation for clinical reasoning in the diagnosis, prognosis, and choice of interventions for chronic conditions, of which breast cancer-related lymphedema is a chronic condition. There are differences to the use of outcome measures, and those differences even exist between professions. Knowledge of and competence to the use of outcome measures are routinely reported as barriers for the use of outcome measures in evidence-based practice. The relevant literature that I investigated referred to the ICF model as the foundation for categorizing outcomes. The World Health Organization developed the ICF model, and that stands for International Classification of Functioning, Disability, and Health. It is a framework for describing functioning and disability in relation to a health condition. The ICF model focuses on 3 domains: body functions and structures, activities and participation, environmental and personal factors. Now, for each of these domains, there may be a number of outcome subdomains that would pertain to a specific health condition like breast cancer-related lymphedema. And for each outcome subdomain, there may be one or more outcome measures. So from this foundation, I furthered my literature search to investigate what outcomes and what outcome measures to the health condition of breast cancer-related lymphedema were being researched. Specifically, I was really interested in identifying outcome measures that were valid and reliable and had good clinical utility for individuals treated for breast cancer-related lymphedema. And I found 5 foundational documents that use domains of the ICF model to categorize outcomes. And they are the oncology section of the APTA Evaluation Database to Guide Effectiveness Task Force. And there's 3 articles here that I found. And from here on out, we'll just call this the Breast Cancer Edge Task Force. It's a little easier to say that. The other article was the Breast Cancer Edge Task Force Clinical Practice Guideline for the diagnosis of upper quadrant lymphedema secondary to breast cancer. And another article was the Dutch Society of Dermatology Dutch Lymphedema Guidelines. So these studies also provided groupings of outcome measures recommended for clinical use. There were 30 outcome measures for body structures and body functions ICF domain, and 31 outcome measures for the activities and participation ICF domain. But that's not all, because in addition to these, while I was investigating the literature, I found other outcome measures used in the clinical and research settings that were not included in these foundational documents. They included 12 outcome measures for body functions and structures, and 19 outcome measures for activities and participation. Well, if you've been counting, altogether, there were a total of 92 outcome measures that I investigated in my literature search and were a part of this study. So I also searched the studies and the literature on facilitators and barriers to the use of outcome measures on breast cancer survivors with breast cancer-related lymphedema. And I discovered that this topic has not been explored at all, especially in light of certified lymphedema therapists. Therefore, the purpose of this study was to examine outcome measures used by certified lymphedema therapists on breast cancer survivors with breast cancer-related lymphedema and their differences between professions, to examine the characteristic predictors for the use of outcome measures, and to examine those facilitators and barriers which influence certified lymphedema therapists' use of outcome measures and their differences between professions. This was a cross-sectional study using an online survey to gather the data I needed. I developed a survey through Qualtrics, and it was aimed to gather demographic information, information about levels of use of outcome measures, and information about levels of agreement of facilitators and barriers to the use of outcome measures. Now, the outcome measures category, it had 2 ICF domains. They were body functions and structures and activities and participation domain. Let's look at the body functions and structures domain first. This domain had 8 outcome subdomains, and they were joint function, flexibility, strength, volume, pain, sensation, tissue consistency, and body composition. Now, for each of these subdomains, there were a number of outcome measures. In total, there were 42 outcome measures for the body functions and structures domain. The respondents scored on a Likert scale their frequency level of use for each outcome measure, being frequently, occasionally, seldom, and do not use. So frequently meant that they used the outcome measure for initial examination and reassessments. And occasionally meant that they used the outcome measure for initial examination. Seldom meant they used the outcome measure intermittent as warranted. And of course, do not use, meaning do not use. Now, the activities and participation domain had 5 outcome subdomains, which were patient-reported, health-reported quality of life, and patient-reported upper quadrant function, patient-reported fatigue, mobility and balance, upper extremity activity, and motor control. Here again, for each of these subdomains, there were a number of outcome measures. In total, there were 50 outcome measures for the activities and participation ICF domain. And again, the respondents scored on a Likert scale their frequency level of use for each of these outcome measures, being frequently, occasionally, seldom, and do not use. Let's take a look at the facilitators and barriers category. Here, there was 5 domains, and they were beliefs of therapists, knowledge and competence, healthcare practice, business structure, and healthcare equity. The domains had a few statements that the respondents would score on a Likert scale of agreement, being that they strongly agree, neither agree or disagree, disagree, and strongly disagree. In total, there were 38 statements. Now, the face validity of the survey was confirmed by 4 certified lymphedema therapists and 2 researchers with survey experience. Prior to disseminating the survey, I conducted a pilot study with 15 respondents to determine if the purposes of the study were answerable with this survey, and they were. And then I ran, prior to disseminating the survey, I conducted a pilot study with 15 respondents. I then ran content validity analysis with 6 certified lymphedema therapists from the pilot study. And these content experts took an additional survey that investigated the clarity and relevance of the survey items. And this confirmed the content validity of the study with an item level content validity index of 0.99. I used convenience sampling with 6 institutions willing to disseminate the surveys. There were greater than 7,000 emails with a survey link that were disseminated. Due to the convenience sampling, though, there was crossover distributions. The inclusion criteria were certified lymphedema therapists, and the exclusion criteria were certified lymphedema therapists that did not see breast cancer-related lymphedema. There were 130 certified lymphedema therapists that responded to the survey, and there were many professions, as you can see: PT, PTA, OT, CODA, massage therapist, nurse, and physician. Now, many of those professions in the data set were too dispersed for meaningful interpretation. And so it was also determined that some of the professions did not routinely use and interpret outcome measures as part of their legal practice. Therefore, I narrowed the population to OTs and PTs. And we analyzed 111 certified lymphedema therapists. 41 of them were occupational therapists and 70 were physical therapists. 98% of them were female, and the average age was 48 years. 50% of the physical therapists had clinical doctorate degrees, and 51% of the OTs had master's degree. 63.9% of the respondents were LANA certified. 50% of the respondents did not have any additional specialization beyond their CLT certification. Their average years in practice was 22.7 years. I discovered that this study's sample was similar to an international and national studies. And this suggests that this study captured an equitable sample of the population at large. Okay, so let's get into the outcome measures. We're going to look at the use of outcome measures. So for ease of reporting, I collapsed that Likert scale to use and do not use. And then I also used quartile cut points to group the outcome measures. And that distributed the range of their use into equal probabilities. Represented here are the 15 outcome measures used most often in the 4th quartile. 10 out of the 13 outcome subdomains were included, and they are volume, joint function, tissue texture, sensation, pain, flexibility, body composition, strength, upper quadrant function, and patient-reported health-reported quality of life. Now, there were a few group differences, and 2 of them are found here in the 4th quartile. They are stiff glenohumeral joint, in which PTs use this outcome measure more than OTs, and then the lymphedema life impact scale, in which OTs use this outcome measure more than PTs. It is important to note that the group differences that I investigated were not associated with an additional specialization or a CLT training institution. I have identified the measures recommended by the Breast Cancer Edge Task Force in this fourth quartile, and they are circumferential measurements for volume, goniometric measurements, both active and passive range of motion for joint function, the numeric pain scale, and if you look down a little bit farther, the visual analog scale, both for pain, and then the stiff glenohumeral joint for flexibility, hand grip dynamometer for strength, and the quick dash for the patient-reported upper quadrant function. Here, these are the 15 outcome measures used least often from the first quartile. The most affected outcome subdomains were patient-reported outcome measures for fatigue and also the upper extremity activity and motor control. There were no group differences in this quartile. In this quartile, there are measures recommended by the Breast Cancer Edge Task Force. And what is interesting is that all of these measures are all patient-reported measures on fatigue. I conducted a binary logistic regression to examine unique predictors to the use of outcome measures, and I discovered that profession and LANA certification status and highest earned degree are predictors to only 6 of the 92 outcome measures, and they are all located in that third quartile. So moving forward with the results, I examined the facilitators and barriers to the use of outcome measures. The Likert scale used for this category was also collapsed, and it was collapsed to agree, neither agree or disagree, and disagree. There were many facilitators and barriers with equitable distributions. Those that had a larger distribution are presented on this slide. And what's interesting here is that all these statements are located in the domain of knowledge and competence. What we can see here in this table is 46% agreed that they had sufficient knowledge about outcome measures for breast cancer-related lymphedema. 70.3% agreed that they had sufficient skills to use outcome measures. 67.3% agreed that they had difficulty knowing the best outcome measure to choose due to numerous options. 62.8% did not agree that they received sufficient training about outcome measures in their professional education. And here's a nearly equal split. 45.5% agreed and 44.5% disagreed that they received sufficient training on outcome measures in post-professional CLT education. I also focused my attention on the group differences related to the facilitators and barriers. And what I discovered was that more physical therapists, certified lymphedema therapists, disagree that the use of outcome measures improve quality of care, help in clinical reasoning for choice of interventions, improve efficiency of evaluations, and determine intervention efficacy. In addition to this, more PT certified lymphedema therapists were uncertain if the use of outcome measures improved communication with other healthcare stakeholders. So the study had a few limitations. The first is the inability to generalize the findings despite the equitable sample comparative to an international and national studies. This is because I use convenient sampling, and despite my efforts to encourage participation with a reminder and a prize drawing, the sample size was meager compared to the distribution of 7,000 surveys. However, I also want to bring back to your attention that there were crossover distributions from individuals who attended more than one school or were a member of more than one association. The survey required respondents to recall if they used how frequently they used listed outcome measures, and this yields to some recall bias. There were 91 discrete questions in the survey that respondents attended to, and that may have resulted in survey fatigue. So these are the 5 conclusions for this study that relate to the purposes. First, I identified 5 outcome measures used most often. And as a side note, there were more outcome measures used most often on body functions and structures than on activities and participation. 2, there were group differences in use of outcome measures, but no trends in associations with specializations or schooling. Profession, OT and PT, LANA certification status, and highest earned degree predict the use of only a few of the outcome measures. Use of outcome measures were valued by OTs and PTs, but they weren't valued equally. And lack of knowledge of outcome measures and lack of education on outcome measures are barriers to their use. So complementary to those main findings, I am also recommending that the outcome categories established by the Breast Cancer Edge Task Force be modified by parsing out the patient-reported upper quadrant function and adding the upper extremity activity and motor control outcomes. These outcomes can be considered as a baseline for a Delphi study investigating a core outcome set. I am also recommending a core set of outcome measures based off of the work done by the Breast Cancer Edge Task Force, the Clinical Practice Guideline for Diagnosing Breast Cancer-Related Lymphedema, the Dutch Lymphedema Guidelines, and the distributions of the probability of their use that I identified in this study. These complementary findings will lead to future research. In summary, I have presented today that the lymphatic system is a major body system and that lymphology aligns with the APTA vision statement. And I have examined in my 3 studies how lymphology is integrated into the field of physical therapy, including entry-level physical therapy education, post-professional education, and physical therapy practice. I have discovered that most DPT faculty agree that topics of lymphology should be taught in the entry-level curriculum, except for complete decongestive therapy. Of note, there is no standard of what should be taught, though. I've also discovered that a core outcome set and a core set of outcome measures for breast cancer-related lymphedema is needed for researchers and clinicians alike, and that more randomized control trials are needed to show the effects of manual lymphatic drainage techniques in combination with compression and/or exercise in the orthopedic physical therapy specialty. Education is the gateway to lymphology and evidence-based practice in physical therapy. This dissertation lays a foundation for future research endeavors to build upon. I'm interested in investigating DPT programs that offer CDT specialist certifications and those that offer lymphology education without certification. Definitely, we should examine a core outcome set and a core set of outcome measures for breast cancer survivors with breast cancer-related lymphedema using a Delphi study. We need to explore the efficacy of manual lymphatic drainage techniques in combination with compression in orthopedic physical therapy practice using randomized controlled trials. I want to return back to those facilitators and barriers because they had equitable distributions. And I want to examine these facilitators and barriers to the use of outcome measures, and I want to add qualitative research methods. I want to investigate the content currently being taught in post-professional CLT education on examination and outcome measures. So there was recently a LANA survey that was just conducted that could answer some of these questions that I'm going to take a part of. And finally, there needs to be more observational studies to complement outcome measures for comorbidities. Currently, I have IRB approval to conduct a cross-sectional comparison study to investigate reaction time and movement time in females with breast cancer-related lymphedema. So I've attached some references here. And I really thank you. I appreciate your time and attention. And now I will open the rest of our time for questions.
Thank you, David, for that presentation. We will now take questions from the audience. Please raise your hand using the icons below where it says reaction. Raise your hand and we'll call upon you to unmute yourself. And you can ask David your question, or if for any reason you're unable to do that, please feel comfortable typing in your question into the chat box and we will ask it for you. Thanks, Jennifer. Go ahead and ask your question.
Well done, David. Excellent presentation. I enjoyed all the pieces and parts. And one of the questions I have for you is, you mentioned that there's 15 outcome measures, and that there was 15 outcome measures essentially that were recommended. And I wonder, in that survey that you sent, are you able to, did you guys gather information about work setting? Like, might there be something to say that they work in an outpatient setting versus inpatient versus an academic setting? So that's my first question. I'm gonna let you answer.
Yeah, and the answer to that question is definitely there were questions about their profession, if they were academic. There was also a question about their clinical setting, and we had their outpatient, and we also had inpatient, acute care, and we kind of dispersed that for like 4 different categories, and they were outpatient setting, an outpatient setting connected to a hospital, an inpatient setting, and like we also had a setting for like long-term care. And what we had to do is we had to kind of collapse that into just 2 settings, being outpatient and more of an inpatient setting, because there just wasn't enough respondents for all those categories. So we did look at that, and I did put that into the binary logistic regression, and it really didn't come up.
So part of the reason why I'm asking is if you had enough of a sub-analyses to identify those individuals that work in academic settings, and then find out which measures that they're choosing, because they may be choosing to use those in practice, but they also might be choosing to use them in their education. And I think this concept of if with the identification of those 15 outcome measures that are recommended on your slide previously, like that ties back into that original study to say, okay, if we say lymphology is a thing that should be an entry-level education, how are we teaching that? And to kind of go and survey those individuals might be a nice opportunity for you. The other thing that I would suggest is that you mentioned like kind of changing some of the oncology edge recommendations or something like that. So get with those original authors, because of course they're going to go over them every 5 or 10 years, and get on that EDGE task force, and then be a part of that change. Because I think it's interesting, your work, and I've watched, I think the first 2 or 2 manuscripts that have already been published, and so I've looked these things over, and I think they're really adding to this body of knowledge. And so encourage you to get in with those thinkers if you can, post PhD, and share your knowledge and passion with them. So it was very good. Thank you.
I'll have to find out how to do that.
I'll connect you.
Okay, that sounds great.
Thank you, Dr. Blackwood. Betsy Campione, go ahead and unmute yourself.
Great job, David. I was thrilled to be able to carve out the time to sit in today. As you know, David, I've got an interest in implementation science, and I'm actually building a mixed method study that's looking at CPGs versus outcome measures. So I'm curious, you talked a little bit more about the knowledge of the clinicians in terms of understanding outcome measures, understanding how to use them, or not necessarily understanding which ones to choose, right? And I think those are overwhelming things for all clinicians, given the volume of ones that exist. I'd be curious to know, though, when you were looking at this, did you look at any other barriers or facilitators that come from sort of the context? So I think the last person who just asked that question, Jennifer, asking about setting. But I'm curious because we all have other organizational constraints that may or may not allow us to implement certain things into our workflow. We know that it can take time to fill out an outcome measure. Who's responsible for that? Does my administration support it? How am I storing it? So there's all these other things outside of just the clinician making choices. Did you explore that at all, or get any information or think about that in terms of?
I actually did. Just give me 1 second while I page down there, because I think that's a really interesting point. And I actually thought we were going to pick up on something pretty substantial for that. But it was all really, they were all just had some very equitable distributions across the board with agreed, neither agree or disagree, and disagree. But so the category, the domain was business structures. And so, I use things like, does management at your workplace support the use of outcome measures? Do you feel that you have sufficient time to conduct a battery of outcome measures? Do you feel that you have sufficient time to analyze them? So there's a lot of time things related to the workplace. Also, do you have colleague support? And then we even talked about like their documentation method. So did you use EMR, or did you use paper, and things like that? So I think there's like 8 or 10 questions in this area that we did look at business structure more. But again, if I look at a lot of these distributions, they really need to be parsed out a little bit. And I really think, and I just this week I talked to the IRB that approved the study and said, is it possible to go back, and because I have all these emails from their prize drawing, and I asked them, is it possible to go back and do some qualitative research to really understand this more thoroughly? And they said, yeah, you have to kind of document these things, and if it looks okay, and I think we could do that. So I'm kind of excited about that to further this on.
Great, thank you.
Yeah.
Chad.
Hi, David.
Hey, Chad. How are you doing?
I'm good. How are you? It's nice to see you.
It's good to see you.
You did a great job today.
Thank you, Chad.
I have a question about your study 1. So some of the questions you asked seem to be more fact-based, right? Like how many hours are in your program and things like that. But some of them are opinion questions. And I'm wondering if you worry about generalizing those findings. When they were stating, the questions were asking a lot about the importance of lymphedema, when 38 out of 43 respondents were actually people who taught lymphedema.
Right. And so absolutely, there definitely is a current concern about generalizability of that study. And I wrote that in the article that was a concern, because we only had 5 that did not teach on lymphology, which I have to say was really disappointing, because I really wanted that non-biased opinion, because I really, as I stated right at the beginning of this presentation, the lymphatics And edema and all those things extend across all the disciplines of physical therapy. And I showed you the pictures and I gave you the diagnoses for that. And what I really wanted to do is bring in people that don't teach that for that non-biased opinion. And we only had 5. So absolutely, there's a limitation there.
Thank you. And I have one question about study 3 as well.
Okay.
With respect to your logistic regression, I was wondering if you could walk us through the odds ratios and what those things are kind of telling you.
Absolutely. Let me get you there so I can kind of go over that with you.
David, feel free to share your screen again if you think that
Yeah,
would help.
I think I'll do that too.
Yep, go right ahead.
Okay. Hold on. Sharing screen is so tricky sometimes when you got to move. I got 3 screens here and I'm moving things around and trying to make this all happen right. And so
Understood.
probably blundering a little bit, but that's just the way it works. So, all right. So let me see here. Share screen. Got it. You see it?
I do.
Okay. All right, great. So let's go with the profession first. There we go. So in here, we can see the odds ratio for dynamometer, pinch dynamometer is 11.36. And I have to say, this is the largest odds ratio that I had, which is really a good effect size, pretty strong effect size here. And then of course the monofilament with 3. And so what we can say here is that certified lymphedema therapists who are occupational therapists are 11 times more likely to use pinch dynamometer outcome measure to assess strength. And then for the 3.01, we could say that CLTs who are OTs are 3 times more likely to use the monofilament outcome measure to assess sensation. Looking here at the Sharp-Dahl discrimination dash visual analog scale for fatigue, you can see they're all related to not being LANA certified. So again, looking at these odd ratios, we can see that certified lymphedema therapists that are not LANA certified are nearly 4 times more likely to use the Sharp-Dahl discrimination outcome measure for sensation. And then CLTs that are not LANA certified are 4 times more likely to use the DASH for patient-reported outcome measures of upper quadrant function. And then CLTs that are not LANA certified are 3 times more likely to measure fatigue with the visual analog scale outcome measure. And then finally, the highest earned degree being master's degree. So those CLTs with their highest professional degree being Masters of Science or Masters of Arts are nearly 4 times more likely to use functional reach outcome measure to assess mobility and balance. So those are the odds ratios. And again, most of them were medium effect sizes, except for the one for pinch dynamometer, which was a rather large effect size.
Great, thank you, David.
Yeah, thank you.
Jonathan, go ahead and ask your question.
Hi, would you be able to go back to the data in study 1 regarding the hours of lecturing and labs spent studying lymphedema?
Yeah. Okay. I'm gonna be a master at sharing screens when I'm done with it, sure.
I totally feel your pain. I get that.
So this one I'm thinking that you want here?
Yeah, I'm noticing that the means are so much closer to the minimum values than they are to the maximum values. So I'm wondering like maybe what the medians look like. I'm betting that
Oh,
they tend to be a
yeah.
lot lower, and maybe that there's like some faculty in here that they really specialize in this stuff, and that's why like you get some range that's just so much higher.
Yeah. I'd love to tell you what the medians are, but I don't have those studies up with me to tell you that.
Okay.
And that I can't really let you know that, but I would love to send you that information and send that to you if that's possible. I would love to do that and give you that information. But I do agree, though, that when you look at these big dispersed range from 0.5 to 14, obviously there seems to be some outliers there. But when we looked at the data set, there were outliers. It wasn't like there was just 1.5 and 1.14. There was like a 0.5 and a 0.8 and then a 10 and a 14. So there weren't these outliers that were sitting out there all alone by themselves. And so I think it was important to report this information, but you're right, the mean does seem to go down to the lower ends. There were a few hours that were higher. So,
Okay, thank you.
I will gladly get you the median information, though. I didn't pull up that study, sorry.
That's okay. Thank you.
Thanks, Jonathan. Dean Fry.
Hello, David. It's been a while since I've seen you, and I was so pleased to be able to make it to your defense and hear you provide a very nice defense of your research. So I have a question. I understand you're a faculty member now, and
I am.
congratulations on that. So my question for you is, one thing that I always do when I have a conversation with faculty about their research is to ask them, what do you want to achieve by the time you retire? So in other words, what impact will you have on the field before you retire? So I'd love to hear your answer to that.
Well,
That's a big one.
yeah, and it makes me emotional. So forgive me.
Sure.
That makes me emotional because I'm very passionate about the lymphatic system. I really, my biggest goal with all of this, as much as I bring in all the research that I can, my biggest goal is to bring lymphology to a level of importance in the field of physical therapy that would be up there with cardiopulmonary, sports medicine, women's health, all those, that it would come to that level, that we can maybe even have, one of the things that I see with like lymphedema and lymphatics is buried in the special interest groups of cancer. And so I really think it needs to be brought out from there, because I really would like to see lymphologists, physical therapists, so that people can come to them and ask them the questions from experts that study lymphology beyond lymphedema. We can look at lymphangiogenesis and the immune system and so many other things, and just have them as their own specialty group, instead of having it, there's a little group here under oncology and maybe a little group here with integumentary or wound care. It needs, as a major body system, it needs to be its own specialty. And that's what I would really like to see in the field of physical therapy. And then beyond that, I really would like to see our textbooks change on how we treat edema, because we're still using we're still teaching the price, with protection, rest, ice, compression, elevation. There's a lot of studies that are showing now that ice really doesn't decrease edema. And that really, most of them are showing that it's mainly compression. So we are still teaching something's old, and a lot of that old teaching is based on of Starling's equilibrium, which says that your venous system reabsorbs excess fluid. But the new Starling's equilibrium, which by the way was discovered around 10 years ago, it basically is saying that all the reabsorption of fluid and proteins and waste products and all these things is solely responsible due to the lymphatic system. Solely responsible. It's not the venous system, but we haven't changed how we teach it. And that's 10 years old. And so we need to change. So those are my passions, and I hope I can get there.
Yeah, well, I challenge you, David. I know you, I know from the past that you're passionate on this topic, and I'd love to see that passion. And I encourage you to follow through with the EDGE work, to get yourself on the EDGE task group. And also, you said you wanted to change the textbooks. Be that change agent and write that. Yeah, connect with somebody writing, formulating those textbooks, and write that part of the textbook, and put yourself out there. It's great work.
Thank you.
Thank you, Dean Fry. Sarah.
Hi, David. Also, long time no see. How are you?
I'm good. How are you, Sarah?
Good.
Yeah.
So I'm hoping that there's no kids screaming in the background. So I'll make this quick. So I was excited to see you today because I feel like we're both in these, pretty specific subspecialties of physical therapy. And we're both really passionate about, different populations that, the majority of our colleagues really aren't. And so, being more in clinical practice instead of the academic setting, I wondered from your findings in terms of what's really taught in the programs, would your effort be, more advantageous if you were to pioneer a board specialty certification or residency offerings instead of gearing yourself more towards putting more into the general education of physical therapists?
Yes, and I think that's kind of what I was alluding to when I was talking to Dr. Fry, because that's exactly how we need to do this. And I'm not saying that we need physical therapists that are certified lymphedema therapists. I don't even want to take that away from the schools that have been in existence for years. That's great. But what we can do is have a lymphologist specialist in physical therapy. And that, I think that, because that's medical, that's medicine, that extends not just lymphedema, but that extends into so many other things about how the lymphatic system responds to even a pulmonary condition. How does it respond? How can we bring that into the field of physical therapy? What can we do about that? What can we know about that? Those are the things that I want people to get excited about that and be that specialist. Absolutely, Sarah.
Do we have any additional questions from the audience? Go ahead, Jen.
So I'm just going to ask this question. It's related to your dissertation, but really to this area of research. Do you think physical therapists maybe have a concern or disconnect with the term lymphedema versus edema? And because it's kind of shocking to me to say that there's so many that believe that it should be a part of entry-level education, which it is taught, but it's just this issue of saying, are we talking even in the same language? And then any thoughts that you have relative to that?
Yeah, so at the beginning of this dissertation, I went over some my passion. And if you noticed on one of the slides I had, damage to the lymphatic system can result in lymphedema, chronic edema. And so there's a push from the International Lymphedema Framework Society to kind of relabel this a little bit, because the author of the study is Moffitt, and she's an amazing woman. And basically she's going, you know, if it helps us to get the message out, let's just change it to chronic edema. Because really, and this is why I teach students, every edema, so listen, so every edema involves the lymphatic system. Plain and simple, every edema involves the lymphatic system, but not every edema is a lymphedema. You have to have some form of damage to the lymphatic system to have lymphedema. But there's a continuum from edema, which is a dynamic insufficiency of the lymphatic system. And as it progresses, if it doesn't resolve, it can damage the lymphatic system. Once the lymphatic system is damaged and we start going into chronic edema, we now have lymphedema, which is a static insufficiency of the lymphatic system. So that's why it extends across all disciplines, because we see all that.
Thank you.
Yeah.
Thank you. Any other questions from the audience?
I'd like to say one more thing to that too, because I think sometimes we think of damage to the lymphatic system as being something that has to be like a blunt force, an incision, radiation, scar tissue. All these are deep wound that destroyed a lot of lymphatics, but that's not the case. You can have lymphedema from prolonged edema that, again, what it does is it causes what we say mural insufficiency, which means the vessel fails, and valvular insufficiency, meaning the valves fail. And once that happens, there's damage to the lymphatic system. And so that's another form of damage to the lymphatic system. Oh, you're getting me off on teaching, so I'll pull back. Or else you're just going to hear all, you're just going to have a big lesson about the lymphatic system. Let me go get my slides really quick.
Yeah. Thank you. Thank you. Any other questions? Well, I would like to thank all of you for attending this dissertation defense, and thank you for your participation. The public component of this defense is now completed. And so we're going to ask that everybody leave the meeting at this time by just pressing that leave red button on the bottom corner. And so we will continue then with the private component of this. So thank you very much.
Thank you.